Thank you for joining my presentation on when the diagnosis becomes unaffordable. My name is Terrence Shenfield, and I've been an education coordinator for the last 30 years in a major trauma center. When you think about this topic, it's a medical ethics topic. Many patients have been diagnosed with illnesses that cost a lot of money to maintain. Say, for example, cancer. The cost of cancer medications may skyrocket past $20,000 a month. Many different companies offer these wonderful cures, but people can't afford them. Some people have insurance, some people don't, some people don't have enough insurance. So at the end of this presentation, you'll learn a lot more about what's going on in regard to healthcare, especially when your diagnosis becomes very unaffordable. Today's presentation is going to consist of two case studies, one of Ms. Franco and the other one of Ms. Williams. It's also going to talk about the role of health insurance and end-of-life care. A lot of times health insurance doesn't cover certain medications and that are involved with the end-of-life care. And also we're going to talk about preventative screening and illnesses. If you don't have good insurance, I'm sure you're not going to have good preventative screening. We talk about cancer care and the expenses with it. We talk about chronic disease management, cardiovascular disease management, asthma, and COPD. All of these are very common chronic diseases that occur with people, especially as you get older, and they are not cheap. So let's go into a little bit more detail. So how expensive is healthcare in the United States? I am sure you all know that many people don't have insurance or don't have enough insurance. When you talk about cancer patients typically have an out-of-pocket expense of nearly $12,000 a year, and that's just for one drug. In 2014, there were over $4 billion spent in out-of-pocket cancer medications. And the funny part is, as these new pharmaceutical companies come out with new medications, they charge an enormous amount of money for them. Sometimes insurance companies don't even cover these new cancer drugs. For example, newly approved cancer drugs cost an average about $10,000 a month, and some can be as high as $30,000 a month. So when you, God forbid, you get cancer or someone you know gets cancer, the out-of-pocket expenses for management of cancer is so ridiculously expensive. There are so many good ads out there. There's so many new medications out there that may be able to help people and save lives, but people cannot afford it. I wonder, what's the point of doing research and investing in new medications if people can't afford it? So let's talk about another one, congestive heart failure. This is a big issue in America. The typical monthly medication and supplement maintenance doses that people take is around $705 a month. Sometimes the insurance premiums could be an average about $750 too. So when you really think about it, you know, if you do get sick and you do get congestive heart failure, you do get cancer, your monthly expenses is going to be astronomical. I don't know many people in America who can really afford it, except for the 1% who really make some big money in this country. So out-of-pocket expenses are enormous. And the question is, you know, we got the best health care in the world, but people can't afford it. I have very good insurance. I have an Aetna PPO. God forbid I get sick. I don't know what my out-of-pocket expenses would ever be. And I'm sure I'm not alone. I wanted to go over a couple of case studies with you. And this first case study is on Ms. Franco. Ms. Franco is a self-employed seamstress with no health insurance. She is 54 years old and has been in good health, has never smoked, and exercises 3 times a week. In September 2017, she began experiencing episodes of chest pain that occurred mostly after meals and in the evenings before going to bed. Occasionally, the episodes occurred when she was exercising on a stationary bike. Initially, she ignored the symptoms but began to worry as they worsened over time. She noticed a loss of appetite and her trousers became loose. One afternoon, she took the bus with her sister to the walk-in clinic. Mrs. Franco did not have health insurance, and as a result, she was required to make a $38 prepayment at the front desk in order to see the physician. Once she was paid and the physician saw her, the physician listened to her story and then performed a physical exam. The physician thought that her symptoms were caused by heartburn. Based upon the history, she said this has nothing to do with your heart, but it has a lot to do with acid in your stomach that regurgitates up your esophagus, which causes pain, which seems like it's a heart attack. But she says at this point, she thinks the biggest problem right here could be heartburn, and this could be managed with some Nexium or some other type of over-the-counter remedy. The doctor continued and said that she also wanted to consider two other important diagnostic considerations. She thought it was heartburn, but to really get a good understanding, she wanted to do two tests. One would be a cardiac stress test, and the other one would be endoscopy. And the cardiac stress test would look for signs of coronary artery disease, and the endoscopy would rule out cancer of the stomach or esophagus. If these tests were normal, she would simply treat her for heartburn with some medications and some dietary advice. She also informed Mrs. Franco that the test would be over $1,000 to rule out these two conditions. When Mrs. Franco heard the price, she was a little bit set back, and she thought maybe I could just treat her heartburn empirically with a proton pump inhibitor. The problem with just treating her with a proton pump inhibitor is if she did have some kind of underlying cardiac condition or underlying malignancy in her stomach, the consequences of a delay in diagnosis could be really harmful. The longer you wait to find out what's going on with you, especially with cancer, the greater risk you are. The doctor also thought about ways that she could reduce the cost, but it seems like that the hospital that she works at does not accept any charity care. And there was no way she could bring down the billings in the cardiology unit or the gastroenterology units for the diagnostic test to be done. So she was between a rock and a hard place. As Mrs. Franco and the doctor were discussing various options, her time with the doctor ran into overtime. Physicians these days have a set period of time that they need to see patients. But the physician realized that if she did not take care of her, there was a very good likelihood that she was not going to go see any kind of other physician anywhere else. So the physician, really concerned, said she was concerned that she would do the test. She felt that Mrs. Franco needed to do the diagnostic test, even if she couldn't only pay the bill. In other words, she was saying, get the diagnostic test and pay only part of the bill and let the bill go into collection. But Mrs. Franco felt that she didn't like the idea of going into debt. She did not like the idea of a collection agency calling her. So she really didn't want to sit through the diagnostic test, get billed for it, and then not pay it, and then be through the collection agency. She just felt this was not a good way of going. At this point, Mrs. Franco was starting to get really worried and started staring at her feet, and she shook her head and said, "Doctor, I can't pay that much." So the physician suggested, why not she go to a public hospital? And then she immediately responded saying, I don't want to go to a public hospital. My sister and aunt had bad experiences there and tried to obtain services. She said that they lose track of you and make you wait all day to be seen. I can't afford to take the time. So the doctor, realizing that this is becoming a hopeless case, said, really, I need you to reconsider this. Why don't you get the diagnostic test, go into debt, and let them collect the money? But she was really adamant about her position. She didn't want to spend the money. She didn't want to go into debt. And she acknowledged that the hospital staff were overextended and then began to consider other options for her. Although the doctor realized that the standard approach of care for managing such a presentation was to rule out cardiac disease and rule out GI malignancy, she recognized that the odds were in favor that this patient didn't really have neither. The history suggested that her condition was basically gastrointestinal and not cardiac. And she also thought that the poor appetite and weight loss might be related to anxiety rather than the other condition. Somewhere out of desperation, the physician decided to treat her for heartburn. So she gave her a prescription that would cost $117 a month for a proton pump inhibitor. She was also concerned that possibility that the diagnosis was wrong, and so she wanted to see her in anywhere from 2 to 4 weeks. And she was especially anxious to see if she continued to lose weight, because this actually raises the suspicion of malignancy. So the physician was concerned, but she treated her with a proton pump inhibitor, and she wanted to see her in 2 to 4 weeks. As Mrs. Franco was leaving the office, the nurse was able to provide her with some samples of proton pump inhibitors for free. They were supplied by the pharmaceutical representative. The doctor actually reduced the fee for her visit by writing off the professional component of the bill, and it was not in her power to cancel the clinic portion, but she undercoded the visit as a 15-minute visit rather than a 30-minute visit. So she did the best she could for her, and Mrs. Franco left the office. 5 weeks later, Mrs. Franco was admitted to the emergency department because she was vomiting blood and had significant weight loss. She required emergency intubation to protect the airway. She was admitted to the ICU, and at that point they ran full diagnostics on her. And as a result of the diagnostic test, they came up that she had a diagnosis of stage 3A stomach cancer. The 5-year survival rate for this stage of cancer is 20%. Now what? Do you think her story is unique? How many patients across this country actually are uninsured? How many patients across this country are underinsured? How many patients like this can't afford the health care that's on the table? I work with this woman. She is in her mid-50s. She's probably not the healthiest woman in the world. And her and I were talking, and she was saying that she had a $5,000 a year deductible. And I said to myself, oh my goodness, $5,000. So she told me that she really doesn't go to see the doctor very often, because if she does go see the doctor, everything comes out of pocket. I don't know about you and me, but to spend roughly $500 a month on going to see the doctor and not get reimbursed, to spend $5,000 a year and not get reimbursed, who can afford that? I think that in this country, many patients are not screened properly. Many patients end up coming in with late stages of diseases. Many patients suffer from chronic disease and not managed. A lot of people use the emergency services as their primary care. So this is a real mess. This is a very sad story about Mrs. Franco, and this is not unique. Many patients across this country have the exact type of situation. So what is the role of health insurance and your survival from illness? What that means is, if you don't have insurance, do you think there's a greater likelihood that you're going to die from some kind of chronic disorder? And the answer is absolutely yes. A new study finds that there are approximately 45,000 deaths annually linked to lack of health insurance. When you think about this, the uninsured working age Americans have a 40% higher death risk than privately insured counterparts. So what that means is, if you have insurance, your survivability is much higher. In several specific conditions, the uninsured have worse survival rates. For example, if you have congestive heart failure, hypertension, diabetes, asthma, COPD, all of these conditions, if you don't have health insurance, you're probably not being managed properly. And if you're not managed properly, you're probably increasing the risk of death. Lack of coverage is associated with lower use of recommended preventative services. This is a very, very important part. So many of us use preventative services. I know I do. I know I go to my doctor every 6 months and they check my blood sugars and they check my my hypertension, which I don't have. They check my chemistry. They see if I'm okay. So basically, if you don't have insurance, you don't do this. You don't really have an idea of how healthy you are or how sick you are. And at present, there is approximately 28 million Americans who are uninsured. So the concept of not having health insurance or not having good health insurance or having a high deductible increase your risk of death. So how does the United States compare with other countries in regard to health care? When we think about health insurance, we provide the same medical care as other countries. We use the same medical technology. I want to make a little caveat there. We develop new medications that come to market, like I was telling you before about the cancer medication. The problem is no one can afford it. When a new medication comes to market and costs anywhere from $10,000 to $30,000 a month, who can afford it? So the problem is we have a large number of people who are uninsured, and if they're not uninsured, they're underinsured, meaning that their deductible is so high they do not access preventative services. The result is that we end up spending so much more money with charity care and other types of methods and writing off debts. We remain the only major country that builds its healthcare system around private for-profit insurance companies. So what that means is we have our Aetnas, we have our Horizon Blue Cross Blue Shield, we have our Cignas. All of these companies are on the New York Stock Exchange. All of them pay their stockholders. The goal of these companies is to make money. So the problem is we, the people, suffer from this. So let's get a little bit more into the impact on services with no health insurance. What I mean by this is that people with no health insurance, which is a significant part of our country, the problem with that is they miss primary prevention and screening services. What I mean by this is I go see my doctor every 6 months. My sugars are a little bit high. I have to manage it with some metformin and dietary restrictions, which I hate, but I do what I got to do. So the point is, I get screened. I use primary prevention services. I see my doctor, but people who don't have insurance don't access the doctor. People who have a high deductible don't access the doctor. So the primary prevention and screening services that are readily available are not utilized. The result is that patients end up getting more sick and sick. In regard to cancer care and outcomes, if you don't have insurance in this company, you really are in a very problems area. So, for example, if someone has some kind of stomach pain, they might write it off as a regurgitation or, gastric reflux, and they might take some Tums or something like that. But it could be some form of stomach cancer. So the problem is, if you don't have insurance, you don't access the service. Let's talk about chronic diseases, which is a lot of them, especially with our elderly. I'm talking about diabetes, hypertension, end-stage renal disease, HIV, and mental illness. I would have to say that in regard to end-stage renal disease, we actually have a pretty good system in this country with or without insurance. But diabetes, hypertension, all of these different types of illnesses are actually not managed very well, especially for those who do not have health insurance, which can later lead into end-stage renal disease. Hospital-based care like emergency service, traumatic injury, cardiovascular disease. If you don't have health insurance, a lot of times the poor people or the underinsured people will access the emergency room as their primary care. And I don't need to tell you how expensive that is and how it doesn't utilize the services properly. What this results is overall mortality and general measures of health status. What that means is that there's an increase in mortality and actually a decrease in the care given to patients. So it really has a significant impact on all of these variables. When I was conducting my research for this presentation, I came across a very good study that looked at cultural disparities in medical screening with or without insurance. So what I found was that Asian women are predisposed to getting cervical cancer. There are higher rates of cervical cancer, higher rates of mortality versus other populations. Now, we all know that the way to sort of screen for cervical cancer is do a pap smear, but it seems that Asian women are kind of resistant to get the pap smear. I don't know why. I'm not going into the details why they don't do it, but this is what the studies show. Also, they found that Korean American women were hesitant to get mammograms, so the rates of breast cancer are higher and the severity of the cancer is higher. Kind of odd facts. And finally, I wanted to talk about African American patients and the idea of colorectal cancer. Basically, African American men in particular are hesitant to get screened for colorectal cancer. And the problem is they are higher rates of cancer, colon cancer, than other groups. So actually the recommendation is that they should be screened at the age of 45. But for whatever the reason is, African American men are actually hesitant to get screened for colon cancer, and as a result there are higher rates of it. I just thought it was kind of interesting to talk about these little disparities and how it impacts with culture. I was thinking of actually putting a presentation together on this. Just a little food for thought. The old saying, the ounce of prevention is worth a pound of cure. This goes for healthcare. When you do screening services, when you have health insurance, just like I do, and probably just the way you do, you are screened by your doctor once or twice a year. They actually do a physical exam on you. If you have any kind of chronic conditions such as diabetes or hypertension or asthma, you're probably managed by the doctor. They'll prescribe different medications and to see how you're doing. The problem is that many people who don't have health insurance or have health insurance that with a high deductible don't utilize preventative and screening services. Some of the big areas is mammograms, colon cancer screening, diabetes screening, cholesterol screening, and also management of hypertension. So mammograms, if you don't have insurance, you probably, if you're at the right age group for being a woman who needs to, be screened for mammograms and see if you have any kind of breast cancer, especially if you have a history or genetic component to that. If you don't have insurance, you don't access care. Colon cancer, I just told you about the screening for colon cancer. Typically, they keep on changing the age, but I don't have a family history of colon cancer, but I had my first screening at 55, and then I was all clear, and they said, then you should do it in 10 years. So, but there are a lot of people who have a history of colon cancer in the family, and they don't access the screening. And this especially goes for the people who don't have health insurance or they're underinsured. Diabetes is running rampant in this country, so you really need to be screened and you need to manage disease. Cholesterol, same thing, So I know a lot of people who don't get a yearly checkup. I think I was speaking earlier about a woman who has a $5,000 deductible each year, and can you imagine why would she want to spend money for an expensive laboratory test out of pocket? And the problem is that, she can have high cholesterol and potentially go into heart disease and so on. And hypertension, this is another one. A lot of people walk around, don't even realize they have high blood pressure. So all of these things are preventable. The key point to this, a lot of these conditions are preventable with proper screening. And if you happen to have any of these conditions, early treatment is the best thing. Management, like managing your diabetes, managing your cholesterol, managing your hypertension, all of these things are really important things that you could do to prevent death. So these kind of things don't work well for those who are underinsured or have no insurance. I wanted to talk to you a little bit about cancer care and outcomes. Basically, uninsured cancer patients typically have a worse outcome than those who have insurance. They typically die younger, they have more severe cases, and the bottom line reason for this is a delayed diagnosis. So if you're screened properly and you know what your diagnosis is, an early treatment regimen is the best thing. But if you don't have insurance and you don't get screened, the likelihood of you having an advanced case of cancer is really high, and then the mortality rate is much higher too. So some stats: breast cancer kills approximately 40,000 women each year. And if you think about it, if more people got mammograms and did some preventative medicine to be screened for this, probably maybe less deaths. Colon cancer is the second leading cause after lung cancer of deaths, approximately 57,000 deaths each year. And I was explaining to you before, like African American men don't really get screened for colon cancer. They just feel they don't want it. And they're actually recommendations at age 45. And then people who have no insurance, or if they're underinsured, like with high deductibles, they don't get screened. So this is the second leading cause of death after lung cancer, really pretty severe. When we think of prostate cancer, they say men who are uninsured or underinsured get advanced prostate cancer at nearly 4 times the national average. And also advanced disease mortality is higher with the uninsured. What that means is people don't get screened. Men don't get screened if you're uninsured or underinsured for prostate cancer. And then they are more likely, almost 400 times more likely, 400% more likely to have cancer, advanced cancer, prostate cancer. So, this is the whole concept of screening. If you have insurance and you can get screened for these conditions, you have a better likelihood of survival. And that's the point I'm really making here. The number one killer in this country is cardiovascular disease. And let me just start off saying this. The prevalence of hypertension and elevated LDL cholesterol is similar for the insured and the uninsured. What I'm saying is that you could have risk factors for cardiovascular disease, and it doesn't matter if you got the best insurance or if you got no insurance. The key point here is how you manage it and how you're screened. They've shown that, and I'm not getting political, that under the Affordable Care Act, 10 million adults with cardiovascular disease gained coverage. What that means is that you had 10 million adults who had cardiovascular disease now had access to medications, had access to treatment for their heart problems. So health insurance and cardiovascular mortality is tied in very close. So the key point here, and I'm not getting political again, is that the Affordable Care Act actually made life better for those who had chronic heart disease. And what has to be done in the future, I don't know, but this is some stats that we could talk about heart disease. The cases of diabetes in this country is running rampant. Diabetes, which is a severe chronic disorder, has really impacted many people with those that don't have insurance. According to some stats, 2 million American adults under the age of 65 years of age reported that they have diabetes with no health insurance coverage. This is really a significant public health and economic ramifications. What they found that the group that has no insurance, they made 60% fewer physician office visits. They prescribed 52% fewer medications. They access the emergency room 168% more than other people. And here's the real kicker. It costs roughly around $1,700 for 3 months supply. So you could do the math. Having diabetes, managing your diabetes is costly, especially for those who don't have insurance. So if you don't have insurance, and probably the reason you don't have insurance is because you probably have some economic hardship. Who can afford $1,700 in 3 months? So what happens is the diabetes goes into renal failure and so on and so on. And you know all the cases of diabetes that gone chronic. So diabetes is a big problem. A lot of patients who have diabetes and hypertension who are not managed properly end up going into end-stage renal disease. I'm not going to say the word luckily, but in the United States, public health insurance is available for those who have end-stage renal disease. So you can get dialysis basically for free in this country. I just wanted to show you something. More than 10,000 uninsured patients sought care at a Texas emergency department for life-saving kidney dialysis in 2017, incurring more than a $21.8 million hospital cost. So what I'm saying is, so many people are accessing the healthcare system who are uninsured. And in this small Texas hospital, they spent approximately $22 million in hospital costs. Medicare spends approximately $35 billion annually on the care for beneficiaries with end-stage renal disease or kidney failure. So when you really think about it, if there was preventative services, if you managed your hypertension, if you had no insurance, but you were able to access care and you manage your hypertension, we would not be in the mess we are right now with end-stage renal disease. Very sad. I wanted to talk about the health insurance access and care for HIV patients in the United States. Typically, HIV patients have very limited access to insurance coverage. Typically, Medicaid covers most of the cost for HIV. They made a special, Congress put a special law passed. It's called the Ryan White HIV/AIDS program. And this program is funded from the United States and actually supports a lot of patients with HIV in regard to the care they get. Again, a lot of patients with HIV don't have health insurance, and they access care through the Ryan White HIV/AIDS program, which is federally supported. In this country, we have approximately 43.4 million adults who have mental illness. Mental illness can be defined as anxiety disorder, bipolar, could be schizophrenia, could be depression, could be panic disorders. It could be a whole host of mental disorders, but the more important fact is that there's a lot of people in America that have it. Studies have shown it's more prevalent amongst women than men, like 21% versus 14%. 20% of adults ages 18 to 25, 20% of adult ages between 26 and 49. So 40% of mental illnesses occur before the age of 49. People with mental illness typically can't keep a job. If you have a panic disorder, how are you going to be working unless you're on a proper medication? So you're out of work. When you're out of work, that means you don't have health insurance, so you don't manage your health and you don't manage a mental disorder. They say 37% of the working age adults with severe mental illnesses were uninsured for at least part of the year. So the point what I'm making is health insurance is primarily accessed through the job. And if you're not working, you're not going to have access to health care. And mental illness is a great reason why people can't work. If you have any kind of these disorders that I just mentioned before, the likelihood of you being a good candidate on a job, and more importantly, you keeping the job, is very low. COPD, or chronic obstructive pulmonary disease, is very common here in America. The side effect of smoking for many years, you could end up getting COPD, but there are other risk factors. In this country, there's approximately 30 million patients who have been identified as having COPD, but there's probably many more that have not been identified. COPD impacts women more than men. In the past, it was men had more cases of COPD, but recently, in recent times, it's more women. The symptoms of COPD is not a diagnosis. Just because you have a smoking history and you're coughing up sputum in the morning, and you doesn't mean you have COPD. The gold standard to determine if someone has COPD is spirometry testing. A lot of times the people who don't have insurance manage their COPD with an anticholinergic medication, which is unnecessary. In other words, it's not going to treat it. To treat COPD, you really need inhaled corticosteroids. There are some good medications on the market. One is Advair, Combivent, Spiriva, but all of these medications are very costly. For example, Advair costs about $286 a month. Combivent, which it costs $243, where Spiriva costs again $286. So if you have insurance, you could probably manage to get these inhalers rather inexpensively. But if you don't have insurance, you're going to pay about $815 a month out of pocket for these medications. I don't know about you and me, but I don't think I could spend $815 a month for medications. I mean, luckily I have insurance, but the whole point of this whole conference is that people don't have insurance. How about asthma? National estimates show that many patients who have asthma actually get the medications they need. The problem is that many of the people who don't have insurance access the emergency room as their primary care. They also go to clinics. Another problem with that is many of these patients who access the emergency room as their primary care don't manage their asthma effectively. Typically, if you manage your asthma properly, and this is if you have insurance, if you don't have insurance, you'll have less frequent bouts going to the emergency room. So asthma is a real problem, but it seems like we are offering insurance or programs that could give free medications to these patients. The problem is these patients are not being managed properly for asthma, and that has nothing to do with insurance. That has to go with education that they get when they have asthma and how to use an inhaler, how to use a controller medication. This is an interesting slide. It talks about hospital-based care, which means that you're admitted into the hospital. Also, it talks about emergency care. So the findings for these patients who are admitted to the hospital, uninsured patients who are hospitalized for a range of conditions, number one, experience higher rates of death in the hospital. Number two, receive fewer services. Number three, more likely to experience an adverse medical event due to negligence than an insured patient. So let me just say something. The number one part, experience higher rates of death in the hospital. I imagine that the uninsured patient actually doesn't maintain their condition very well. So if you have some kind of chronic disorder like heart disease, hypertension, and you are uninsured and you don't manage yourself, when you're finally admitted to the hospital, I think you're more critically ill than someone else. In regard to emergency care, there was a lot of studies showing that since the Affordable Care Act that was put through, there was less reliance on emergency department visits as their primary care. So the point is this: if you don't have insurance and you get really ill, you're going to access the emergency room as your primary care facility. And even though the Affordable Care Act had a lot of problems with it, at least offered a temporary solution. And again, I'm not getting into the politics of this whole thing. This is our last case study on Mrs. Williams. Mrs. Williams is 50 years old, is gaunt and pale, but she appears much older when she meets with the doctor. She reported to the doctor that she had no past serious illnesses or surgeries, but she admitted that she smokes 2 packs of cigarettes per day for the last 30 years. The physician does an exam on her and tells Mrs. Williams that she would like to order a chest x-ray and a complete blood count because she suspects that she might have pneumonia. And so Mrs. Williams says, pneumonia again? I've had that 2 times in the last year. And she gets really sort of upset about the concept she might have pneumonia. So Mrs. Williams says, I was treated for pneumonia 4 months ago. So Dr. Garrison orders a new chest x-ray and actually brings up the old x-ray. And so that's the x-ray on the right. So the doctor notices an abnormal area in the right middle lobe. So the radiologist reported that this was an anatomic variant likely related to pectus excavatum with an infiltrate distally. So this was the x-ray they did 4 months ago, and this is the report from the radiologist on that x-ray. So the new x-ray was done on Mrs. Williams, and the distal infiltrate is gone, but the area that was known as anatomic variant appears larger and more defined. So I just wanted to point out this area right here. You could see that area right there, and that is much clearly defined compared to the last one. And the doctor is concerned about that. The question is that a pneumonia or is that lung cancer? You don't know. But, there's a definite difference between the 2 x-rays of this one and the other one. So the doctor meets with Mrs. Williams and says, I was comparing your x-ray that you just took now with the one that you had before, and I'm concerned about an area that just doesn't look right to me. It could very well be a pneumonia, but I just want to be very careful about everything because I really want to rule out everything. And I'm going to treat you with antibiotics, but given your smoking history, I really have some concerns. And I'm concerned about there's a possibility this may be cancer. The only way that I can really determine what it is if I do a CAT scan of your chest. So can we get a better idea of what's there? So basically, the doctor recommends her getting a CAT scan because they want to rule out either it's pneumonia or if it's cancer, and that's the best option to do at this point. Mrs. Williams is silent for about a minute, and then she looks up at the doctor and says, Dr. Garrison, I've thought about lung cancer because my cousin just died of that, and he smoked a lot too. But I don't have any health insurance. I just started a new job and I'll be eligible for health insurance in 90 days. I really can't afford the CAT scan now. So can we wait to get the CAT scan until after I have insurance? My cousin didn't have insurance and their family went bankrupt paying for this treatment. Now he's dead and his wife and kids got nothing. So basically, she wants to wait 90 days so that her health insurance is enacted to get the CAT scan. So you heard the story, you know the case. What is her options? What is Miss Williams' options? Should she wait 90 days? Should she put the money on a credit card and just pay off the credit card? What do? You think it's kind of unique that someone holds off on medical care because they don't have insurance? What would you do? Is this case study unique? Do you think this is the only time this happens to any one person? I could tell you absolutely not. People do this all the time. People wait till they have health insurance. They hold off. But in this particular case, you have 2 x-rays, one different than the other, and one pretty pronounced, but we really don't know if it's a bacterial infection or a viral infection or if it's cancer. So what role does charity care play in this? Should she try to go get charity care and just go to the bill? What should you do? What would you do? And my final question to you, is this an example of delayed treatment? And I think this is an example of delayed treatment. And this is what causes a lot of death in America for those who are uninsured or underinsured. If you're diagnosed with something and you get the proper treatment early, your survivability is much higher. So Mrs. Williams is in a dilemma. She doesn't know what to do. And is this case unique? Absolutely not. And I'm going to let you come up with your own judgment what happens in the end. In summary, I want to thank you very much for joining my presentation. I hope you enjoyed it. And I just wanted to give you some information. For example, preventative care is better than acute care. So many illnesses present themselves early, and if you manage them early, the prognosis is so much better. When you're thinking about coverage, you should know your resources, and you should try to seek out some free coverage. If you have any kind of chronic disease, you should seek out some free coverage. I don't know if the healthcare system in this country is going to change anytime soon. I still think we're going to have a ton of uninsured people. It's a very political thing rather than a thing good for humanity. Also, if you have any kind of chronic disease, you really got to manage it because it's only going to get progressively worse. Here is some very good resources on the concept of no insurance or underinsured, especially with chronic diseases. And I want to thank you very much for joining me, and I hope you really enjoyed this presentation. Thank you so much.